Now I would like to invite Dr. SHAIL VASAVADA, because what we are talking about the normalized, normal adult eyes. Now, which IOL has to be implanted for the pediatric age group, particularly from the infantile age group to the years of 12 years, 13 years of eyes. So, Dr. SHAIL has a wide experience about the IOL power implantation in the pediatric population. So, let's hear from him. Dr. SHAIL, please.
Thank you very much, Dr. Twinkle sir, for this wonderful course. At the outset, I would like to acknowledge the contribution of my colleague, Dr. Deepa Agrawal, in making this presentation. We do receive research grant support from Alcon Laboratories, but has no relevance to this presentation. I think accurate determination of the IOL power is one of the most major challenging parts in children undergoing cataract surgery. Unlike in adults, where all of your pre-operative planning usually ends up being right in 8 or 9 out of 10 eyes. In children, it behaves very, very differently. It's just not a small adult eye. It's an extremely different ball game altogether. So for IOL power calculations, we need the biometric measurements. The IOL power, which formulas to use for such eyes, and the target refraction, which is of extreme importance in these eyes. The major difficulty is that unlike in adults, although you may have access to all the best equipments in the world, children in most situations are not going to be cooperating enough for you to take measurements on those wonderful instruments. So whenever possible in older children, cooperative children, which generally doesn't occur before 3, 4 or 5 years of age, try to get optical biometry and readings with the machines like you would do for older adults. However, for children typically less than 3, 4, 5 years of age, or sometimes even older children who are very uncooperative, it would be very difficult to do any form of examination in the outpatient clinic. And therefore for them, examination under anesthesia is the mainstay, not just for IOL power calculation, but for a complete thorough examination of the eye. Quite often we think it is cataract, but it turns out to be fetal vasculature with remnants that have been left behind, and so on and so forth. So you need to do a detailed eye examination along with IOL power calculation. Generally the handheld autokeratometers work reasonably well under anesthesia in such eyes. And the keratometry, there are several articles to suggest, average keratometry at different ages as well. So if you otherwise struggle or find it difficult to measure, you can use these formulas, these tables as well. Wherever possible, immersion biometry is definitely the way to go in measuring the axial length compared to contact. It will be difficult to do immersion biometry in very, very small children, and therefore, like in our case, we've got a customized Prager shell made of a very small size, because even that normal Prager shell may be difficult to fit in very young children or children less than 3, 4 years of age. And like in adults, there are also articles done amongst children to show that measuring with the contact method does have significant limitations in measuring the axial length. And like I said, alignment is also an issue. Coming to the IOL calculation formulas, unlike like we saw in the adults, where you have now 2 or 3 good formulas which seem to work across all different ranges like the Barrett's, Kane, Hale, RBF, Olsen. In children it is very different, and if you actually undergo or go through the review of literature, there are several articles, and each of the articles seems to recommend a different formula, and that is because the eyes of children behave very differently. The eye itself behaves very differently if you operate at 3 months versus you operate at 3 years versus you operate at 10 years. So therefore there is no still one good consensus which can tell us that this is the formula to go to. We did our own studies, our own data analysis of our own pediatric cohort, and in our case we found the SRKT and the Holiday 2 to be the most accurate, and personalizing a constant like in adults didn't seem to help very much in children. We are still struggling. We are trying to get our data sorted out with the Barrett's formula as well, but there are several challenges that we are still facing. So maybe in the coming times this may change. But as of now, these are our 2 formula of choice as far as pediatric eyes goes. Coming to the important question of how much do you target refraction? Do you actually undercorrect, keeping in mind the growth of the eyeball that is going to occur? If yes, then by how much? Or do you go for target emetropia? So there are two schools of thought. One is if you go for closer to emetropia, which is not much of undercorrection, you are less likely to have too much of amblyopia in the beginning. But the chances of ending up with myopias of 10, 12, 13, 14 as they grow up are very, very high. And therefore the principle of leaving behind some amount of residual hypermetropia or undercorrection at the time of primary surgery, which has a slightly higher chance of amblyopia immediately, but lesser chances of extreme myopias occurring in the future. And that is one theory that is followed most commonly. Because myopic shifts will occur no matter however good the surgery may be. Also, the age of surgery is also a very important determining factor for the rate of axial growth. Because the maximum growth occurs in the first, from birth until 18 months of age. So the maximum axial length grows between 0 to 6 months of age, then 6 to 18, and then 18 months onwards the axial growth really slows down. So it will also depend on if you are operating less than 6-month-old child or a child at more than 5, 6, 7 years of age. There are, once again, like keratometry, there are normative databases to suggest in a normal eye what would be the growing pattern, but however these are meant for normal eyes, and a cataract eye may behave quite differently than a normal child growing eye. The rate of axial length we found in our study was higher in children less than 1 year of age, and it was higher in pseudophakic eyes compared to aphakic eyes, and more so in unilateral pseudophakia, which means if a child has a unilateral cataract, that eye is likely to grow much, much faster and much longer compared to a normal eye, the fellow eye which doesn't have cataract. So the key consensus that all pediatric surgeons follow is to undercorrect the eye depending on the age and the laterality. So it depends on the age of the child, the axial length. Say for example, if the child is already myope as of now, keeping in mind his age and what the normal axial length would be, you think differently. And if it's a unilateral cataract, like I said, you need to keep in mind two factors. One is amblyopia and also anisometropia with the other eyes. Once again, there are several articles to suggest a blanket sort of undercorrection, like this suggested by Plager and group, that as per the age, you undercorrect by +5, +4, +3, so on and so forth. Dr. Trivedi and Dr. Wilson and their group have once again also suggested, based on age, that younger the child, more the undercorrection. With our data analysis, this is the pattern that we follow, that in a very young child, less than 3 months, we undercorrect by about 35%. And as the child keeps growing older, we undercorrect lesser and lesser, to the fact that anything beyond 6 to 7 years of age, we hardly undercorrect. That is, we undercorrect only by about 2 to 5%. But younger the child, more the undercorrection. That is the consensus across all of these articles. So I'll just share 2-3 case scenarios to highlight that. This was a 4-month and 20-day-old child, bilateral congenital cataract, having normal, similar axial length in both eyes and normal for their age. So keeping this in mind, that he falls into this category of 3 to 6 months, we are looking at an undercorrection of about 30% from his actual power. So when we calculate with using the SRKT, the emetropic power turns out to be 36, and doing a 30% reduction in this, that would be deducting 10 diopters. So 26 is the rough power that we would choose for this eye. Which this child underwent, and these are his subsequent sequential refractions post-operatively, starting from 1 month until 5 years post-op, where he is now left behind with roughly a diopter or so of hypermetropia, meaning that the undercorrection of by about 30% worked reasonably well for this child. And with meticulous occlusion therapy, he's been able to achieve 6/12 vision at this point of time at 6 years of age in his life, which is quite good. A word on toric IOLs, and toric IOLs are useful in older children. That is for two reasons. One is the keratometry, the basic keratometry tends to stabilize around 6 to 7 years of age, and then the major changes occur only after 40 years of age. And second is you need children to give good measurements to even consider toric IOLs. So ours is probably the largest study of toric IOLs amongst older children, where we have taken children 7 years up to 15 years of age. And what we did found that the mean post-operative refractive astigmatism drops significantly when you are using toric IOLs, and all patients had a pre-operative astigmatism of minimum 1.5 diopters and more, average being 3.5 diopters. And you can even do a posterior capsulorhexis with an in-the-back toric IOL, which means that the toric IOL stability doesn't change over a period of time. And it's a good tool in reducing amblyopia. And the final case, 8-year-old with insulin diabetes dependent IDDM and needing a toric IOL significant, like we found with our calculation T5, because he was older. We didn't do much of undercorrection, and is doing well now 3 months post-operatively. We've also done a PCCC, therefore no YAG has been required. Multifocal IOLs have been debated and thought of, but they do tend to reduce the contrast. And I think in a growing eye, our aim is to develop the vision. Children adapt to glasses very, very well. So for us, definitely multifocal IOLs is a no-no. Probably the newer generation extended depth of focus IOLs may have some promising future in older children. We have very limited experience as of now in less than 10 eyes of children more than 13 to 14 years of age who seem to be doing well. So summarizing the talk, accurate biometric assessment is not as easy as in adults. You do need examination under anesthesia in most situations. The basic formulas of SRKT and Holiday-2 work reasonably well. You need to undercorrect based on the age, axial length and the laterality. And the real challenge of pediatric cataract surgery starts after the surgery, along with parents, because it's a long journey to overcome amblyopia. Thank you so much for the patient listening.
Thank you.